Afternoon once again, everybody. It is my pleasure to welcome us to this webinar, which is titled Financing Health Coverage for the Informal Sector. We're looking at lessons from Nigeria. This afternoon, we are going to be discussing this very important topic, which has to do with the informal sector. We know that the informal sector is a part of an economy that is not fully regulated, neither regulated by taxes or by government. And we also know that it includes activities and jobs that, although they have market, they are not formally registered. And the informal sector, we know, is a global which can include each wide such as hairdressers, private taxi drivers, cars, and other artisans. It also can have people in the construction industry, the workers. This informal sector is very important because it provides economic all over the world. Access to affordable quality healthcare remains a significant issue, particularly in Sub-Saharan Africa, in low and middle income countries of the world, and especially here in Nigeria. We know that the info accounts for over 7% of the workforce. Is a need for this group of sure that this large and vulnerable group of innovative financial solutions. Therefore, this webinar, Financing Informal Sector Health Coverage in Nigeria, will delve into the financial mechanisms that can help expand health coverage for the informal sector. We are going to approach this webinar in this way. The keynote address will be given by the Chief Engagement Officer we're going to have a keynote address that's after the address is delivered. We'll have the keynote address person. And then after we have a presentation that will be done by Dr. Nasiru Ikaru. It's going to be talking financing solutions. Thereafter, we are going to have questions and answers, and then we'll go into the first panel discussion. The first panel discussion is going to be discussing finance coverage for the informal sector, lessons from Nigeria. And there we have as our panelists, we have Alhaji Aliyu Yusuf, who is a partner. Introduction to be done after this. The introduction of personalities is going to be done after I have done the general introduction. So after the first panel discussion, we are going to have a few minutes for question and answers. And then we'll go into the second presentation, which is going to be the political economy of financing health coverage for the informal sector in Nigeria. This is also still going to be taken by Professor Banwell Amadason. And thereafter, we will go to the second panel session. The discussion is going to also have, as panelists, a few people who are going to be introduced to us soon. And thereafter, we'll have the third presentation, which is on health coverage for the poor and vulnerable, constitutional and legal matters arising. This is going to be taken also by a professor of international law and diplomacy. Ladies and gentlemen, I believe that we are going to have a very nice time here this afternoon. We are going to have our knowledge enriched as we share experience and knowledge. And I believe that we're going to come up with a means of expanding access to health coverage for the informal sector. Having said that, I'd like to welcome you again to this meeting as I invite Dr. Hope Uweja for the welcome address. Over.
You can listen.
Over. Dr. Hope. Dr. Hope, please.
Yeah, thanks a lot.
Yeah, the welcome address.
Yeah, thanks, Dr. Guinea. First, on behalf of the Board of Trustees, the Board of Directors and Management of Africa Economic Forum, I really wish to welcome our very distinguished partners, welcome our very distinguished resource persons that have been drawn across various sectors. In particular, I want to welcome the executive secretaries and director generals of the various state agencies that are present here. I really want to appreciate them and thank them for finding the time to be here. We also want to thank our representatives from our part grace this occasion, taking the time from their very busy schedules. And then, of course, the strong teams representing Economic Forum, distinguished ladies and gentlemen. It's a great pleasure that I stand before you today to welcome you to this important event on financing health coverage for the informal sector in Sub-Saharan Africa, with a focus on lessons from Nigeria. This event promises to be insightful and informative, and I hope it will provide a platform for robust discussions on how we ensure that everyone in the informal sector full services. Health coverage is a critical aspect of human development.
Information. Please, Professor Madison, unmute yourself. Can somebody get to Professor Madison through another means to tell him to unmute himself? We're not hearing him.
Who is having his number? He should call his private line.
Yeah, that's what I think Dr. Hope will do that. He seems to have started the presentation, but we're not hearing him. He's not audible.
Hello?
Yes, hello.
Can you hear me?
Who is speaking, please? Professor Madison, are you there?
Go ahead, I can hear you. Go ahead, I can hear you.
We cannot hear Madison.
We cannot hear him at all.
Yes.
Can we proceed to the next speaker? Then we'll come back
We
to
are not hearing him. Well, I guess that's what we should go to now. Since we are having issues with Professor Amadason's keynote address, we will need to go to the next item on the agenda. And that agenda will be the presentation, the first presentation that's going to be taken by Dr. Nasiru Ikaro, It is going to be on digital health financing solutions and its role in driving health coverage in the informal sector. Dr. Nasir Karo was formerly General Manager of Information Technology at the Nigerian National Health Insurance Authority. So please, let's welcome Dr. Nasiru Ikaro to make the first presentation. Thank you.
Okay.
Dr. Ikaro, over to you.
Yeah, thank you very much. Can everybody hear me?
Yes, we can hear you.
Okay. Is my presentation going to be put up there, or I should put it up myself?
I'm fine, sir. Okay,
It's
I'm
already
in a
been
Zoom meeting, but I will check it. I'll check it.
Okay, so I have the presentation here, but I don't know, it's not on the screen yet.
Have you sent it to the office so that
Yes,
they can
I
project
did send it.
Okay, so let them put it on the, let them project it now. Or let me share the screen.
Which of the topic is Professor
Please, if you are not officially recognized, can you mute your mic, please?
Okay, can we see my presentation now?
We can see it now, yes.
Okay, I want to greet the members here present listening to this conversation, this presentation today. Like you said, I've had the opportunity to work with everybody here one way or the other before I settled at the headquarters and retired in 2022. So I'm here to present on the digital health financing solution, its role in driving healthcare coverage in the informal sector. In the course of this presentation, we will look at universal health coverage in the informal sector and what that digital health financing solutions. We'll look at some financing solutions. And of course, for the purpose of this presentation, we'll look at digital healthcare financing solution in driving healthcare coverage in the informal sector. So when we talk about universal health coverage in the informal sector, as well as, I mean, this is also applicable in the formal sector. There are three components. You have the physical access, which has to do with the physical facilities, and then human resource for health, the adequacy, and how that affordability. Is it out-of-pocket expenditure, which is not encouraged, or is it through health insurance? Also, you have quality healthcare as a component, which can be done through effective monitoring to ensure that the healthcare services that are provided at the facility level is of good quality. These components all have technologies that drive their various processes. But we will look at the processes that this is a wheel I have designed for this purpose. The processes that drive digital health financing in the information sector include enrollment process, and then you have enrollee verification, which has to be done at the facility level when the enrollee wants to access care. There is accreditation process, which is done by the relevant accreditation authority to ensure that human resource for health and also the facility is it meets the standard for accreditation. There is also the benefit plan. What the benefit plan does, if there are no standard benefit package for the program, and then if it is a pick and choose kind of package, then you have to have a benefit plan to drive that process. What about encounter when the enrollee, when the enrollee goes to the facility and is accessing care? We need to be able to have a process to reach that. What about record management is important. If the enrollee wants to change some kind of information on the record they've already presented at the point of enrollment. Complaints, there are complaints in the system. There should be a process to drive that. Service authorization, it's at the secondary and tertiary level of care. There should be a process to drive that. Then payments across the system or in the system, it has a process to drive it. And then contribution collection or premium collection for enrollment, there should be a process to also drive that. Then claims, if there are claims in the system, there should be a process to drive claims. And then analytics and reporting pretty much give us a 360 view of what is happening and how the health system itself is performing. So this is what I call the digital health financing solution process wheel. We'll look at some of these processes in the next few slides. So if we look at, for example, the informal sector enrollment process, it is in two modes. You have the online mode, and you also have the offline mode. If it is the online mode, you connect, the enrollee will connect to via the internet to the enrollment portal. At the portal, there is a verification that needs to take place with, in the Nigerian case, with the National Identity Management Commission or Identity Database. And if the person is not in the database, then biometrics have to be captured to update his record at the NITI. And then all the information that is required for that enrollment passes through a staging server for validation in terms of the various fields. If they are all being filled, those ones that must be filled, have they been filled? And then if that is validated, then it goes into the enrollee database. If the enrollee goes to the facility, especially in the informal sector, if he has to enroll at the facility level, he should be able to have access to that portal. That is, the hospital will have access to that portal, and then they will take this enrolling information. And if he has a name, they can also validate that. And then if they validate, it hits the server, and the server will take the information to the enrollee database. If it is offline, then which means there's no connection, especially at the very, very remote area, you should be able to collect not just the information, but do some forms of biometric data capture. And then when you now get to a point where you have connectivity, you can now validate that, and then that information is sent to the enrollee database. Now, the verification process is when the enrollee actually goes to the healthcare facility for care. While it's there, you have to verify that the enrollee is eligible, and then that information you get from the enrollee database through to authority server. And if it is validated, you allow the enrollee to have access to care. Encounter process is when the enrollee actually has been admitted to the hospital, and then the enrollee is treated, and then the encounter data is submitted via the portal into, again, DHFS server, and that goes into the encounter database. Complaints can come in two forms. If it comes by phone or it comes by email or SMS, that goes into the call center. And from the call center, if that particular complaint is one that can be handled at the call center, it goes straight into the relevant department for resolution. But if it is something that needs to scale, I will scale it to the agent's supervisor, and that agent supervisor will now take the information to the relevant department. Service authorization process is when referral is required. That is a secondary and tertiary level of care. If there is a managed care environment, then that goes to the managed care environment for authorization and authorization code, or else it goes to the authority that is managing that process. And then once the code is given, the facility can grant access to care. Contribution collection, it can be done at the portal where you have the application, the bank application server integrated to the portal. You can make payments right there from that portal, or it can be through a POS. Even when you do at a POS, once it hits the bank, there should be some kind of notification that comes back to the portal for validation. And then once the release in, then the rest of the processes will be triggered. Now, when it comes to claims processing, once a claim is sent in by the healthcare facility, there are two views. Can be viewed managed care environment if that exists, and if it does not exist, then it has to be with the authority. And then once the claim is validated, payments are made. Payment process, of course, again, you can do it at the portal level once the application integrated with that portal. And then the fee for service payment is for referrals at both secondary and tertiary levels of care. And capitation is paid for predetermined advance payment for services that is provided at primary care. Okay. In terms of analytics and reporting, the various processes that will feed into analytics of how the health system is, and it also provides information for possible intervention from the authority or from other agencies. In terms of design principles of digital health financing solution, where it is highly recommended that it provides for business process automation that establishes end-to-end paperless environment. There should be some form of mobility in the sense that you can do direct data capture, even metrics at locations on without connectivity. Scalability talks about technology that allows for both vertical and horizontal scaling. Vertical scaling referring to if you have just one server, or that server has the capability to expand computing capacity, storage, and also memory space. Horizontal being instead of having one server, you have a couple of servers that are in a cluster, and use load balancing to do the management of that. Whichever way, it brings stability. But the only thing about vertical scalability is it provides you a single point of failure. If it fails, that's it. But if one server fails, to back up. Now, advanced security capability, authentication, and also for who should access what. Consent model approach, again, they really should have the option, or they have the function of improving the sharing of their information. This is to meet the private privacy requirement of various regulatory authorities. Robust auditing, there should be audit trace, who is doing what at what time. That is with that data timestamp. The solution should also be built on global standards. We're talking about integrating the health enterprise with the integration profiles, health level 7 compliance, and then also with digital imaging and communication and others. And this allows for machine independent or platform independent in deploying the solution. Access channels. It is recommended I use web environment, a browser. Everybody can go there. The stakeholders can go there and access health information based on their authorization. In analytics, you cannot emphasize that enough. Okay, this helps to have analytics that insights versatile enough to include national payment platforms or switches, online payments, and not dedicated to just one platform. So coming to the risk subjects, okay, transparency and accountability cannot be emphasized enough. It's not just on the financial component. It's not just on the financial component, but also is healthcare, quality healthcare being given. So monitoring all that with technology to bring transparency to that provision space. Select coverage, I recall back in the agency when we were doing informal sector registration, we used to go to remote locations, do filling of forms, physical forms, and then those will be collected to the state office to zonal office to headquarters. It took months before you can get enrollees to enter the enrollee database. So that is never efficient, but with technology, is 72 hours. But this is very, very key.
Very clear from what he has said is that he led us digital health financing solutions, and then he first, talked on the issue of the universal health coverage for the informal sector, social access, and the quality, healthcare access. Then he went into the processes that drive the digital health financing, solutions, and he told us step by step from enrollment to analytics and reporting. And what comes very clearly here is that yes, the national identification number is very important for us to be able to have a vibrant and functional digital health financing solutions, particularly for the informal sector. And then he talked also about the technology not being itself, the one that defines processes, but it is the processes that define technology. That technology is just an which ensures efficiency. And also, Professor, please, if you have questions, also the so Amanda, Professor Amanda, are you ready now?
Yes.
Hello,
Can you hear me?
Amanda, are you ready?
Yeah.
Okay. Now, yeah, present your keynote address. You're welcome.
In Nigeria, thank you very much. I want to say, ladies and gentlemen, it is an honor to be addressing you today at this important event focused on financing health coverage for the informal sector in Nigeria. The informal sector plays a crucial role in the economic development of our country. Yet many individuals lack accessible and quality healthcare services. I'm here today to discuss innovative solutions to bridge this gap. It is crucial that we draw lessons from our experiences in Nigeria and explore best practices that can be applied in other countries facing severely. And the informal sector, with over 70% of the population engaged in informal activities, agriculture struggle to afford basic healthcare services. leading to partnership between the sector has made significant strides in recent years in increasing access to health insurance for informal sector workers through programs such as formal sector social health insurance program and the volunteers program. These initiatives have helped to improve access to healthcare services for millions of Nigerians who were previously excluded from the informal healthcare system. However, there is still much work to be done to ensure universal health coverage for all Nigerians, especially those in informal sectors. We must continue to explore innovative financing mechanisms such as community-based health insurance schemes and microinsurance programs to reach those who are most vulnerable and underserved. We must also work to strengthen primary healthcare services to ensure access to quality healthcare services. As we reflect on our experiences in Nigeria, it is clear that there is no one-fits-all solution to financing healthcare coverage for the informal sector. Each country must tailor its approach to the needs of the nation.
We've lost you. Prof, you are no longer audible.
I urge all of you to continue to advocate for policies and programs that prioritize the health and well-being of all Nigerians, especially the informal sector. Together, we can build a healthcare system.
Hello? Hello? Prof, we've lost you again. I guess he was already rounding up before we lost him. Can you hear me, ladies and gentlemen?
We can hear you.
Okay, I think we lost him again.
Together we can build a healthcare system that is inclusive, accessible, and affordable for all. Thank you for your dedication and commitment to this cause. Let us work together to ensure that every Nigerian has access to quality healthcare services, regardless of the social economic status. Thank you.
Thank you very much, Prof. You see, this tech has been a bit of a challenge today, almost halfway. And from what we heard, it's so rich and so insightful. We would wish to out, but for the technological glitch which we had. But the key things we can do this social environment, and poverty, of course, the quality of care that they receive is usually poor, so their poor health account for the investment that they make from out of pocket. Now we went to
we mobilized from MDG fund was almost 500 million then, and 500 million was a lot of money then. But we couldn't, at some point, we were almost unable to spend that money on the health, on the coverage, because we couldn't get the informal sector to come on board. So you see the challenges. So there should be a lot of advocacy. And our belief too that I know there was something that we had to, especially in we of the Muslim faith, that some of them are arguing that you do not pay for insurance is not accepted in the religion or something. So those are the challenges too that we face. Though some we were able to overcome, some, well, they may still be there, but again, that's who we are. And those are the challenges that the informal sector.
Thank you.
Those are the challenges that the informal sector faced, and I don't know whether I need to go on, and I just stop over. Allow somebody else to speak.
Thank you very much, Alhaji Aliu. This is quite eye-opening. Even when there is funding, we see that because of certain ingrained, mindsets and constructs, cultural constructs, people who actually should benefit from this innovation refuse to participate in it, even when they're not the ones that are going to pay the money, even when money was already made available for them. Ladies and gentlemen, you are hearing these perspectives. Please put down your questions as we go ahead. I would like also at this point to call on Nuruddin Mohammed, who is Communications and Policy Advisory Consultant to Kaduna. I know Kaduna has quite a lot of advancement that they have made in digital technology, and then maybe he will share with us how, what their own experience is in financing health coverage for the informal sector, particularly given the fact that they have a relatively more advanced digital technology applications than other states in the country. So over to you.
Good afternoon, participant and the moderator. I hope I've been heard well.
Yeah.
Yes, you have been heard.
Am I audible enough?
Yes, you are audible. Audible.
Thank you very much. As you introduced me, I'm Nuruddin Mohammed, based in Kaduna. I was also formerly of the National Health Insurance Scheme, which is now NHIA. The Chief Engagement Officer has been my mentor and my Oga. Having followed all the presentation and the keynote address, and also the discussion by my another former Oga, Mr. Ali Yusuf, the area I want to look at financing the informal sector from my experience in the field for 17 years, I wanted to bring the context. Let's look at the informal sector. When we are talking about informal sector, these are people that are not organized in terms of income. Their income are not so defined that you can easily track and make them contribute as we can have it in the formal sector. The artisans, the traders, farmers, and so on and so forth. So, in as much as they still attend healthcare in these facilities, are largely out of pocket or donations and so on. So, what I want to bring, the focus I want to bring based on experience is that these are people that are willing to access care, and they are willing to also pay for it because of the necessity involved. But from experience, they are not really sensitized to appreciate the value of contribution. That is putting something down against future risks, health risks. In other words, when you need the health, you may not have money at that time. How do I still access health? So they were not properly sensitized to appreciate that benefit. So in as much as they spend a lot of money going to the hospitals, primary healthcare centers, community pharmacies, chemists, and all that is available to them, no proper sensitization either by government or non-governmental agencies that can make them understand, yes, the issue of health insurance gives you the leverage to have health care even when you don't have money at the point of need. So with that background, I want to give or look at 3 basic solutions or innovative solutions that I think might help in addressing financing healthcare coverage for the informal sector, especially in Nigeria, and more particularly in the northern part of Nigeria. One of it is advocacy, which Mr. Aliyu has touched from his experience that there was not enough advocacy. Yes, advocacy in this case is not just to go and tell them the benefit of health insurance. This is normal advocacy. That's what we discover now in communication, what we call comparative advocacy. Comparative advocacy. What it means is that when you are trying to convince somebody to adopt a particular policy or particular line of thinking, you should be able to bring out the shortcomings in what he's adopting now. Let him see that, yes, what he's on it now is not giving him the best results. Then you now go ahead to compare with what you are trying to get him understand and accept from you. So when you have this comparison before him, it becomes easier for him to understand what you are trying to propose to him, that he should be able to save something for his health when he needs it and while he may not have money for it. That is one. So advocacy is very important, and this can be done through their various groupings. So these informal sector people usually operate in groups, unions, associations, and so on. So that can be intensified through these groupings. And also currently the state insurance agencies that we have, they are most they can be able to convince them to understand the need, because the whole issue is convincing them to save for their health. That is the cross of the matter. They spend money, a lot of them, if you go to the hospital, the community, you see that they spend a lot of money. But when they have it, what if they don't have the money and they have the need for help? So convincing them to do that is what is very important in this case. So the second thing is, while we convince, one of the things that usually make it difficult for informal or even the formal sector is the cost of affording the benefit package. Usually the actual determination of this benefit package tends to be very large and all-encompassing. That makes the contribution rate very challenging. So my suggestion here from experience is that for this group of people, the benefit package can be reduced to take care of basic needs of this group of people that we determine basic care, that we know that these are the frequent ailments that usually take them to the hospital. So we can design this benefit package, and that will be able to give us a very affordable contribution rate that they may not find it difficult to contribute. That is the second aspect I'm looking at it. Then the third is, currently from experience, most of these people at the informal sector level, as I said earlier, they go out of their pocket to attend hospitals, primary healthcare centers, community pharmacies, chemists, and pay money, sometimes even on credit. So what I'm suggesting here, why can't we, as part of the strategy, leave the demand side now? Because when we were talking about financing, we're always talking about the demand, the energized demand side. Why can't we go back to the supply side? Those places these people attend to get care, why can't us collaborate with them, bring them on board? Because they have trust in these people, because sometimes they even take credit. So they have trust in these people. These people can be able to advise them on savings as they attend these places, the hospitals, the primary healthcare centers, the community pharmacies, the chemists, and so on. They can organize them into having some little savings. Based on this minimum package that I was suggesting, they'll be able to suggest saving weekly, fortnightly, whatever, or monthly, so that by the time they will come to attend care, they may not have money. So those savings can be used to now take care of them. So in this case, they are now being captured pool in a systematic way that they are used to. Because we are talking of innovative ways of financing. And thank God these people are aware that the false promises of government that will give you free healthcare is no longer attainable, because most of them, if they even go to the government hospital, they still pay. So payment is not something that they don't know. They know they must have to pay. But how do we organize them in such a way that they can save for that future payment, that they can be able to access healthcare and now contribute to the universal health coverage we are all talking about? So I think with these suggestions, which is out of experience of what we encounter, I think if it is looked at, I hope it will go a long way to
expand access,
improve the financing of the healthcare access of the informal sector. Thank you very much.
Thank you very much, Nuruddin Mohammed. But just a few questions before we go to the next panelist. Do you, in this particular situation, you said some things, I would like you to give a clarification, particularly concerning your third solution that you're suggesting. You said that when they contribute little by little, when they have the money, they make little contributions, so they are captured into a pool. Now, where are they making these contributions? Are they contributing in their cooperative societies, or are they making the contributions to the chemists where they normally go to access care, or to the hospitals, or to the primary health centers, or to the community pharmacies? Where they make this contribution, your solution?
Yes.
Your suggestion.
Yes. You know, when I started, I said, let's look at the supply side, which is the providers now. So, yes,
exactly.
So these people have belief in these providers, and I mentioned them. They go there, they remove their money and pay. And sometimes they may not have money, they will take on credit, which means there is trust between them and their providers. So the provider can now, that is when we collaborate with the provider and enlighten them and train them on how to organize these people into pooling. When you come, because when they come to pay, you serve at the point of accessing care. So they have their record, because from experience, most of these people spending out of pocket. Some people even used to leave some balances with the chemists and the pharmacists and even the hospital. So
are you suggesting, Mohammed, are you suggesting that they open an account with those, supply side outlets where they receive their treatment, to be managed by an organization, or to be managed by the supply side management?
Between them and the supply side, the provider, because all the issue we have is that we're managing fund, managing this, managing that, and the issue of interest, whose interest is taken care of, who will manage it will come. But in this case, bring these people into the UHC net. Bring them into the UHC so that.
Thank you.
Yes. So what do we bring them? So since there is trust between them and their providers, that trust should be solidified, so that there will be, because as I said, they used to take credit from them, which means there is trust. So sometimes they usually leave balances with them for future use. So that can be organized. Beneficiary and the provider. So these are some discussed in detail.
Yes. We can see Dr. is we claim to be the access points for enrollment to insurance scheme. That's someone just said that, and I think it's something it's a welcome thing. Thank you very, very much once again for your contributions into this discussion, this session on ensuring that we actually finance healthcare for the coverage for the informal sector. One thing that comes out very clearly from what you have said is the issue of no proper sensitization. And then you talked very, advocacy. The meat of our advocacy is actually competitive.
Yes.
Them know practicing, and then we provide them the advantages that they stand to gain in the new innovation that we are bringing to them. Yes. And that way, it might be more. Thank you very much. Issue of making providers the gateways for the
package itself.
Oh yes,
should be tailored
talk about
towards
a flexible. Yes, then you're talking about differential, benefit package. Some people will say, oh, well, that is not going to be in line with the principle of equity, where you need to have one basic minimum benefit package for everyone. And but we'll discuss that as we go further. After that, thank you very much, Ahmed. I will go straight to the to Dr. Isaac Apoveta, the Director General of Delta State Contributory Health Commission. Now, again, at a point in time, Delta State is a very robust, ICT driving its health insurance, and there was also quite some money that was available because I'm sure then I knew very well that the governor was very much interested. In fact, he was an ambassador of health insurance in Nigeria. So will you share with us your experience, Dr. Apoveta, on how much of the informal sector you were able to capture? And if there were challenges, what were the challenges and what are the innovations that you are going to suggest for us to overcome those challenges so that we can have more of the informal sector, workers into the thank you very much.
Yeah, yes, I'm happy to be here. Very, very happy to be beginning for putting me into this panel. It is important that we share experiences so that we can progress very fast in the journey to universal health coverage in Nigeria. And then thanks for the robust introduction of this in Delta State. But down to the topic in question. First, let us know what are we talking about, the informal sector. In economic terms, it's defined as the gray economy, a sector of the economy that is not organized, but here they contribute well over 75%, 65 to 75% of the GDP of the country. But because they are funding, their fund something is very epileptic, and they come in small piecemeal, they can't pull funds together to do anything social at a given time. So when to get them in without stressing them for that. But before that, I want to say something about this. The success of Delta in all aspects of onboarding into the scheme was based on certain issues. Of course, you mentioned the robust financing of Delta State. The governor was very, very medical doctor for that matter, who contributed to the National Health Act. And of course, when it came to Delta, he must do much better. He did. But one thing we did, Dr. Ben and I, we ran the chairman and most do in Nigeria is, as we're discussing now, an advocacy with and between the healthcare providers. Everybody must know where you stand and why you want to do what you're. So in Delta, we even it's a public hearing of that law. When was the bill? When was in the House? We moved from there to stakeholder engagement. Our providers, private and public, were called together and we discussed this issue. They contributed to the law, or the bill making that became a law. We moved them to traditional rulers across the country. All the traditional rulers in Delta State were put together in 3 zones, Delta Central, North, and South, and we had a sharp discussion with them. And of course, we moved them from town hall, President General and Secretary of every village in Delta State were pulled together. We discussed extensively what we're about to do in the state. And of course, we moved to town hall meetings and so on. And of course, engage the care providers. Having done that, we launched the scheme. But informal sector was a big, serious nut to crack. First, ignorance. Like somebody mentioned in this panel, people were even afraid to give their photograph to you. I remember someone would say, oh, are you wishing us to be sick? Why do you say you contribute money up front, waiting for sickness? That money will make us sick. So you need to do a lot of advocacy, convincing to bring them in. But having done that, we're able to do certain things. One, you must consider subsidized model. You can't give a premium like you do 12,000 a year, 18,000 a year that the state, the federal government was doing. It's not possible in a local environment where a barber will be able to pay that money at a sweep. It's not possible. And so in Delta, we brought the idea first to the governor and said, oh, our premium by actuarial determination is 12,000. And he asked me to Dapoveta, if you are an informal sector person with your wife and 4 children, can you pay 12,000 times those number of people? We said, okay, let's agree on what they can pay. The government will subsidize. And so we brought the premium to 7,000 naira. And funny enough, if you pay capitation on 7,000 at 500 naira capitation, that's 6,000 naira a year. So the whole money is gone back for the care of the patient. But the important thing, you've got them into the insurance net. So we did that. And how did we sustain that? Sustain that by risk pooling and cross-subsidization, ensuring that some people are paying higher, the civil servant, they're paying, the informal sector were paying higher, the organized private sector were paying higher, 35,000, 40,000 per annum, and then against 7,000. And so you pull this one together, mix it up, and then you have an average premium that could run your scheme. We did all this. And then we went further. Even at that, we find that the informal sector were having difficulty in buying into the scheme. So we went to grouping them together. We have Barber Association, Cooperative, Keke Rider Association, and so on, and offer them a loan. Even the 7,000, we still give them a loan to pay at 100 naira a month, over 8 months, over 9 months, a flexible payment system. And how did we get this fund? It wasn't from government. We made the private sector, the commercial banks, Bank of Industry, and we put the fund together. The bank was one loaning the money to them after profiling these groups. Because if you give them from your insurance agency, they will think it's a government money, I will not pay back. But they collect the money from the bank, 7,000 naira. It's a group, times 20 person in the cooperative. And the leadership of the cooperative are the one being monitored to help us ensure that their members pay. And so with that, we have got a good number. I think we have the highest of informal sector collection in Nigeria, well over 100,000 enrollees in this sector, and fast growing. And then we also devised a method. We find out that alone can't help. So we went into what we call indigent early adoption initiative. We talked to the prominent Deltans, or resident in Delta who is rich, organizations, associations, foundations, to purchase insurance for the needy people, the vulnerable persons. And I can tell you, only yesterday, Monday, I flagged off about 3,000 enrollees into the scheme. And the National Health Insurance Scheme coordinator in Delta State, World Health Organization coordinator in Delta State were with me in Warri, Ughelli, and somewhere in Isoko. So people are helping out. The more agenda of this government is that please let us help our people, our neighbors. So we need to devise so many ways of bringing the informal sector into health insurance. It is very critical because they form well over 220 million Nigerians, and about 80% of them are in the informal sector, if not more than. And if you don't take care of them, the disease burden of the state, the e-health burden of the country and your state is very high. And you know, poor health is poor wealth. Good health is good health. So this is where we are in Delta.
Thank you.
We have been able to use all these mechanisms to achieve a lot of release. Presently, we have over 2.4 million Deltans into the scheme from various aspects of the scheme. Even the 7,000 is what we ask the T-ship to pay. And when the T-ship, that's the students, when they pay, we went further to ensure that they even get treatment during holidays. And we are working on a portability that even they will travel on holidays to another state, they can still get product. These are the kind of things you tell them, and people will buy your product. Insurance product is like selling Coca-Cola. Advertisement, and emphasizing the benefit package.
Thank you.
Inherent in what you're trying to say.
Thank you very much.
This is where we are in Delta, and if the opportunity arises, I can give you more information on this.
Thank you very much, Dr. Poveta. Ladies and gentlemen, let's appreciate Dr. Poveta, who actually has delved into new areas of innovation in ensuring that we capture the informal sector into the health insurance net. And I'm quite intrigued by many of the innovations that he brought up here. I was just going to ask a question. Now,
Yes.
having reduced it to 7,000, and then, you know, we said the benefit package. Now, for those who paid 7,000 and those who paid others, was it exactly the same benefit package?
Yes, clearly the same benefit package. We only put what we call additional package for those who are top level payers, but generally the same benefit package.
Like we have top up.
It's only fair to give equity.
Right?
Yes.
Okay, thank you very much.
Thank you. Are you sleeping? That was my presentation. To the point.
A very short period of time.
I can't hear anybody anymore.
Hello, Professor Brownwell.
We can hear you.
Yes, Professor Brownwell.
Yeah.
Yes, I'm saying, can you do the next presentation? Are you ready? Professor Brownwell, are you there with us? Okay, it doesn't seem to be there, right? So,
Can you hear me?
Professor Brownwell.
Can you hear me?
Professor Brownwell. Okay, are you there?
Yeah, can you hear me now? Yes.
Okay, yes, we'll take your presentation on political economy. We'll take your presentation on political economy of financing health coverage for the informal sector in Nigeria. Over to you now, Professor Brownwell. The political economy of financing health coverage for the
but can you
sector.
hear me?
Yes, we can hear you now.
Can you hear me? Okay.
Yes, we can hear you.
I will not be taking a lot of time. What for us, quite appreciate the importance or significance of that sector. We need to do a kind of conceptual review of the keywords. And the keywords is the political economy and the other is informal sector. And of course, what does political economy mean? It's actually a branch of social sciences that focuses on relationships between individuals, government, and public policies. And of course, it is also used to describe policies set by a government that affects their nations and perhaps nations' economy, including sub-national government. And of course, what is the informal sector? I like to restrict myself to just business activities or non-state actors which are not registered with Corporate Affairs Commission. I hope you are hearing me.
Yes, we can hear you.
So what is our focus, therefore? Our focus, therefore, will be in terms of health this informal sector financing, health financing. How we just have to focus on the relationship between government and these unregistered non-state actors, as far as managing that sector is concerned. So it was very, very necessary that both those who are informed and those who are not informed understand the relationship between this political economy and the informal sector. And of course, the formal sector is largely government. And of course, those who could classify as officially recognized private sector. And of course, having said that, it was also necessary for us to look at who are actually these major actors in the informal sector. And I tried to look at the itinerant drug vendors, the patent medicine stores, the village or rural health workers, and themselves sick, and who offer themselves so one form of financing or the other. It was very necessary. So essentially, these are the people we're actually talking about. These are the actors we're actually talking about. And it is complicated because they are not official. And so what you find is that at the end of the day, most of government finances goes to the official circle and not the informal sector. And that is because of what I'll discuss in the end, the theoretical foundations that underlie the relationship between government and this sector. Now, firstly, if we have to look at the sources of financing for the informal sector, we need to actually identify them. We need to identify them, or else we will not be able to know which of these finances is critical to that sector and which is not critical. Of course, I tried to identify about 6 of them, and they include budgetary allocations. But by and large, budgetary allocations do not actually go to the informal sectors. It does not. It's only a very, very minute aspect of the financing that goes to the informal sector. Then the health insurance. What is the population that is availing itself from the informal sector to health insurance? So again, you find out that this sector does not actually have what it takes in terms of financing. Aids and grants. Where do these aids and grants go to? These are actually the sources of finance as far as health sector is concerned. Where do they go to? Is it the formal or the informal? But again, taking a look at it, it goes to the formal, not the informal. That's the basic truth. Now, of course, private capital, this is largely where the finance comes from. And like Dr. Akpovera said, you know, that is the sector that actually funds itself. It is not, there's no government fund. The issue is, why is there no government funding of this sector? Even the relationship is blood. I mean, it's too fluid to be recognized. Too fluid to be recognized. That's the basic truth. So why is it so? And of course, you have exemptions and subsidies. Who are those that are exempted in the informal sector? And who are those that are that these subsidies are given to from time to time? And is the subsidies actually still there? And is the exemption still there? This is what actually those who have retired, you know, could get easily in those days. And of course, government was subsidizing drugs in terms of when it comes to having the prescriptions and so on and so forth. Even bed space, government was subsidizing it. But is it still there? These are basic questions we need to question. And why is it not detailed into the political economy of managing the health sector? And not until we understand this, where managing the informal sector will become a mirage. That's what it will become actually, because we need to understand some nitty-gritty that, you know, surround government formulation of policies as far as the informal health financing is concerned, and also not only in terms of implementation as well. And then even the evaluation is not done properly. Again, you look at it, then the out-of-pocket expenses. Is it really there now for them to spend? So these are sources of funding which we need to look at and actually evaluate on their individual stance. You look at them individually and do a thesis on them as to what significant they pose for now and what it will look like in the future. And then having done that, I actually decided to look at some serious political issues, political economy issues that have actually made this sector not to be, I can't even use the word well-funded, to even be funded, in fact, to be funded in the minutest clause that you can find to qualify it. It's because it's really not funded in any ramification. So we must look at these issues. The first is political patronage that overlie health infrastructure financing. Why are the basic infrastructures in this sector not financed? Why are they not financed? What are the infrastructures? We know they run from hospitals to drug delivery systems, to ambulance rescue systems and so on. All these are infrastructures, and they are not in place at all for the informal sector. Everything you have in that respect is for the formal sector. So we need to look at this area. And when you look at it, where any attempt at all, even any attempt by government to even provide some of this infrastructure, which might not be too significant, is tied to political patronage. You vote for my party, I'll provide this for you. If you don't vote, you'll not find it. So political patronage actually determines who gets it and who do not get it in informal structure. So we need to look at this when policies are not made. Then, of course, again, it will also the issue of exclusion and inclusion in policy and decision making is also vital. It's also vital. Government make policies for the informal sectors in terms of health delivery. But do the informal sector participate in these policies and decisions? It's a huge question we need to ask ourselves. Or else the financing will be misappropriated and misdirected. So if we include them, definitely we'll get the result. But we don't in any way. The budgetary process is very, very faulty in most cases. What is the input of the informal sector? The other one is that the informal sector is apprehensive about statutory oversight financing. To a very large extent, you also discover too that because of intrigues, government attempts even to statutorily control the funds that go to the informal sector. And it is not even the government that sources this fund, but actors in the informal sector. And yet government want to provide regulatory oversight. So this is questionable. And not until we do this, the basic need of the informal sector will also not be met. I mean, these are huge issues that, and again, there's a complex working relations with the informal sector. It is complex in the sense that it is not defined. From local to state government to even national government, what you have is haphazard dealings, haphazard relationships with the informal sector. It's all right. We know there are native doctors. Just set up a board, and it ends there. And at the end of the day, perhaps when there's a fanfare about a health program that is about to be launched, you find government inviting them to come and display, to be present, and so on and so forth. But this is not what it takes. What they need is actual funding that will change the landscape of health financing in the informal sector. Then again, there's also power play in allocating resources between informal and informal health systems. It is the man who is at the helm of affairs that determines, whether he's going to pay the piper or not. So, and usually in most cases, you find out that those at the helm of affairs, they favor the formal sector as against the informal sector. And unfortunately, when a lot of them retire from the formal sector, they fall back on the informal sector, and it becomes a problem. We've witnessed where officials, they die because the formal sector they rely on, they don't even have the money to finance the health. That's a health problem or challenges that they are facing. And so what next is to fall back on the informal sector. And of course, you now find that while they were there, they were a kind of power play between allocating to the resources to the informal sector and allocating to the formal